Good afternoon, everyone, and welcome to Let's Talk About Health, a monthly community conversation series designed to increase awareness about important health issues, provide people with tools to help individuals maintain or improve their health or that of their families, and to improve conversations between patients and medical providers. I'm Donna Jacobs, Senior Vice President at the University of Maryland Medical System, and I will moderate today's conversation. Our topics today are long COVID and pediatric COVID vaccines. Joining us as a leading expert, Dr. Gregory Schenk. He is a graduate of the Lewis Katz School of Medicine at Temple University in Philadelphia. He completed his residency in internal medicine at the NYU School of Medicine, where he served as a chief medical resident. He then did a fellowship in infectious diseases at Beth Israel Deaconess Medical Center at Harvard University Medical School, and then upon completion of additional fellowship training in infection control and hospital epidemiology, he joined the faculty at the University of Maryland School of Medicine as an assistant professor in infectious diseases. Dr. Schrank currently sees patients at the R. Adams Cowley Shock Trauma Center, known to many, and serves as an associate hospital epidemiologist for the University of Maryland Medical Center. During the spring of 2020 and the COVID-19 pandemic surges, Dr. Schrank served as an incident commander for the COVID-19 response at the medical center. He now continues to serve as a subject matter expert for the University of Maryland Medical System's vaccine efforts. Before he starts, let me just share a couple of housekeeping notes. His slides will be available to you online in just a couple of days, and you may feel free at any time while he's speaking to put your questions in the Q&A, the question and answer box, and he'll get to as many of those as time allows. You'll also be able to view this session again online in just a couple of days, and more on that later. Dr. Schrank, let me turn to you. Thank you.
Great. Thanks so much, Donna, and welcome everybody. We greatly appreciate you taking time out of your day today to join us for this conversation. Just one other point before we jump into our discussion is that a few times during my presentation, we'll be taking a moment to, I think, a bit more directly engage with one another using a format known as Ask Me 3, where I'll present a situation that may be familiar to some of you or friends and family that are thinking of these questions, these problems that are concerning to them, and we'll walk through what, identifying what the problem is, what we need to do about it, and really clearly stating why that this is such a critical and important issue to the health of ourselves and our family members. So with that, as Donna mentioned, we will be covering two different topics today, and hopefully doing so with leaving enough time for plenty of questions that you may think of along the way. And you'll see that even though it seems like they may be different, by the time we're finished discussing both, hopefully you'll see that the two are quite related to one another. And the first area of COVID that we'll cover today is the topic known as long COVID. And I put here what we know so far, because I think, as you'll see during our discussion, there certainly are many unanswered questions related to long COVID that is a focus of active research. So to frame the conversation, to frame the problem, many of you are familiar with curves that look like the one here before us, the number of new daily COVID-19 cases across the United States on average. And we see here that we've gone through now 4, depending on where you live, 5 surges of COVID-19. And unfortunately, the U.S. is headed in a direction of yet another, going into the formal winter season. In general, when we look at over the course of the pandemic, regardless of what variant we're currently dealing with, about 14%, more or less, of COVID-19 cases are severe enough to require hospitalization, though that does vary a bit based on an individual's risk. So it's not 14% for everybody. It would vary based on your age, where we know that older adults are more susceptible medical conditions that they may have, whether they be chronic heart conditions, lung diseases, some forms of cancers that require treatment and can suppress the immune system, put an individual at greater risk. And then we also clearly know that there are social determinants that place an individual at higher risk. And what I mean by that is an individual's economic status, their race and ethnicity, the communities that they live in certainly all contribute as well, and have been really an important and critical piece of the pandemic that has been a focus of efforts around health equity. So a lot of focus on deaths, as we do know that this week, unfortunately, the U.S. crossed the 800,000 mark for deaths related to COVID-19. But I think what we're going to talk about today, rather than that top line number, the remainder of cases, the almost 50 million individuals that we know have been infected with COVID-19, some of the health outcomes and the longer term consequences of infection amongst them. So I'm going to actually turn back time a little bit before we jump into COVID and talk about what we knew about the long-term complications of infections and critical illness prior to COVID-19. So before the pandemic, we did know, but it was still also early investigation, that there was a link between, and I'll define this in a moment, what's known as sepsis, or critical illness, and long-term symptoms. So there was something known as post-intensive care unit syndrome. So intensive care being the locations within hospitals where the sickest people are cared for, regardless of whether or not it's related to an infection of really any kind of disease. So we know that there are symptoms that remain for quite some time after critical illness. There are issues with thinking, difficulty with thoughts, post-traumatic stress disorder with anxiety and depression, challenges with sleep, also weakness and difficulty in people regaining the same degree of function that they had before their illness. We also know that after sepsis, even if it doesn't necessarily lead to admission to a critical care unit, sepsis being a severe infection leading to hospitalization, we know that there was a link also with long-term symptoms in the diagnosis of sepsis. So each year within the United States, about 1 million people survive an episode of sepsis, and almost a sixth of them will have some form of persistent physical disability. And of all readmissions to the hospital in the United States, 12% of them are following an episode of sepsis. So we know that there is something different that occurs that after one of these episodes, whether it be critical illness or sepsis, that leads to a change in our health that's not quite how we were before. And I think that's where we were just really beginning to go beyond the tip of the iceberg and understanding the implications of this when then the pandemic hit. So I think that I took this from one of the big review articles on post-sepsis long-term symptoms, and I thought it was a nice way of displaying what exactly is occurring with people. So you can see there on the left, stretching all the way across the right, along the top, a gray dashed line that represents what we would measure as our baseline state of health. An individual has an episode of sepsis, they become infected and require hospitalization, and that level of health declines as we become ill. We receive treatment, hopefully we recover, and then when we have resolution, when we recover from that acute episode of sepsis, there are different directions that an individual's health can go in, and some individuals will have a return to close to baseline and then eventually back to their own baseline level of health, that top dark line. Some people, though, we know, will have some form of persistent impairment. And some individuals, especially those who maybe had the most severe episodes of sepsis or had other medical conditions that were really affecting their baseline health before, may even require rehospitalization, and unfortunately some will even die in the next 6 months to 12 months after their episode of sepsis. And so there are different trajectories that people can take. We know also that there have been individual diseases, individual types of infections that have been linked to long-term symptoms. One of these being Lyme disease. Some of you may have heard the term chronic Lyme before, something that we use more in the medical literature, something known as post-treatment Lyme disease syndrome. So this can be anywhere between 5 and 15% of people infected with Lyme disease that have some, looking back to critical illness, you'll recognize that some of these are similar symptoms: fatigue, severe pain, especially in the joints and muscles, difficulty thinking, that persists well beyond treatment with antibiotics. Also, something known as chronic fatigue syndrome. It has a bit more of a scientific name next to it there, but it's all representing what is a chronic set of symptoms that can occur after infection. Some of the links with chronic fatigue syndrome have been viral. Things like Epstein-Barr virus, which is the most common cause of mononucleosis, which many of us are infected with in our early decades of life. And again, this will be a common theme: severe fatigue, chronic pain, swollen lymph nodes, and this is probably where the most amount of work was done prior to the pandemic in developing treatment protocols and treatment regimens to help people recover from what is a really debilitating degree of fatigue. So we'll move then into long COVID, which is really, of course, a phenomenon not defined until the onset of the pandemic, when we discovered this new virus that has been causing millions and millions of infections around the world. So it's gone by a few different names over the past almost 2 years. Originally, what was popular was something called long haulers, long COVID, as we've titled this discussion today. But what I think is becoming more and more common, at least in the medical literature, are terms known as post-COVID conditions or post-acute sequelae of SARS-CoV-2 infection, or PASC, really all meaning the same thing. Physical symptoms, mental symptoms that start to develop either during the acute infection or after the infection and persist for at least a couple of months beyond resolution of that acute infection. So meaning, for most people, infectious symptoms of the acute phase last for a couple of weeks. And we're really talking at least then 2 months beyond that. So around the 3-month mark following diagnosis is when we would start to consider somebody as potentially having one of these post-acute or long COVID symptoms. Like that figure I showed earlier of the curves, this is really a lack of return to our baseline health, what we would have thought of ourselves as how we considered ourselves and our health before the infection, not returning to that state, not explained by anything else. And it's no longer related to that active infection where we were, isolating at home and we're really, sick with either fever or cough. It's well beyond that phase. This is something that has transitioned into more chronic symptomatology. So why does it occur? That is very, very much an active area of research. I will highlight this again when I touch on children, but it is potentially due to the body's immune response to an infection. We know that one of the causes of especially severe COVID-19 disease isn't necessarily related just to the organism, just to the germ itself, but our body's immune system reacting in a very, very inflammatory way to a new germ that it has never seen before. And so similarly, it's thought that long COVID symptoms relate to almost like a chronic degree of inflammation that occurs after infection. And they have measured in the blood of individuals experiencing these long COVID symptoms different levels of inflammatory markers of inflammation, and compared them to people without those symptoms that have also recovered from COVID, and found a stark difference between the two that may explain some of these chronic symptoms, but very, very much an active area of research. And there's an enormous study underway by the NIH at a number of different academic medical centers around the country to further investigate the causes. So then moving on to who is at risk, it can affect, unfortunately, people all across the spectrum of COVID-19 illness. So it is not just those who have been hospitalized and are gravely ill with COVID and go on to recover that are at risk for long COVID. It has even been identified in individuals that have at first mild illness. And it can even be that the long COVID symptoms in these individuals are more debilitating, more severe than the acute COVID infection itself. You can see there the range of people affected is quite broad, and that's because depending on who is studied, whether it be people that were hospitalized, people that were outpatients when they were infected with COVID, people in Europe, people in Australia, people in South America, and Sub-Saharan Africa, it depends on where you're studying this condition and how well it's documented that determines estimates on who is likely to be impacted by it. And so we end up with these ranges that are quite broad. So anywhere between 10 and 50%, and unfortunately I can't be more specific than that at this point in time, but it is not a small number, as you can see. So with millions of infections across the United States, it's also likely that we have millions of people impacted by this, although it may not all be the same amongst them, that the long COVID symptoms may be mild with one or two symptoms that linger versus some people that really have more debilitating and quite impactful disease. The prognosis is also variable, so meaning the likelihood of recovery, it appears to be linked to a person's baseline state of health. So the healthier you were going into the COVID-19 infection, the better the prognosis is for recovery of some of these symptoms, but they can last for months, even those, as I mentioned, with relatively mild initial infection. You can see here that there are a wide array of symptoms that can develop. I think the most common are those that relate to either a neurologic or psychiatric related symptoms affecting our brain health and our mental health. And they're contained there in the purple box that you can see. A syndrome or a symptom known as brain fog, which probably many of you and everybody kind of has from time to time, but really persistent brain fog, poor memory, difficulty thinking, remembering things that may have even occurred earlier in the day, challenges with sleep, chronic headaches, and anxiety and depression as well, especially for those that required hospitalization due to COVID. It can affect how our respiratory status is with symptoms of cough and shortness of breath. Some people experience some chest discomfort as well. I think another very well documented and quite common long-term symptom of COVID is the lack of taste or change in taste, as well as the lack of smell that typically develops early on in infection and may even be for some people the very first symptom of COVID-19, but can linger for quite some time. And even separate from the more formal research studies looking at COVID-19, I have a number of friends, family, colleagues that I've spoken with that recount the long-lasting effects on taste and smell that COVID-19 infection can have. Like the other post-infectious or post-critical illness syndromes I described at the top of the talk, muscle pain, joint pain, and severe fatigue are also quite prominent. So I would say the purple, green, and yellow or orange boxes are probably contain some of the more common symptoms that people do report. So I introduced this concept at the start. You asked me three. So we'll talk about this problem and develop a solution together. So 2 months ago, I was diagnosed with COVID-19 when I was tested before traveling. I only had a runny nose and a headache at the time, but now I feel so tired that I can hardly manage to leave the house and often feel like I can't remember things I did earlier in the day. So, like I described, somebody with what seemed to be mild COVID-19 infection, but has gone on to develop long-term symptoms that appear to be even worse than the original infection, and it's certainly impacting their quality of life more than the original infection. So what is the problem here? Like we've discussed, long COVID or post-COVID conditions can occur in up to 50% of adults after infection, even if the initial symptoms were mild. What do I need to do? Talk to your doctor, who can help to determine if these symptoms are in fact related to your prior COVID-19 infection or if they have another cause entirely. And so I think it's tempting in the midst of the pandemic to attribute many of these symptoms prior to COVID infection, but one of the most important things and the reason to go see your doctor, talk to your doctor, is to try to distinguish it from something else that may be new that would be important to separately diagnose. Why is it important for me to do this? Long COVID can certainly significantly impact a person's life, their ability to work, perform their day-to-day activities. And so seeing your doctor to discuss developing a treatment plan, establishing a diagnosis is really the most important first step. Okay, so let's talk about vaccination and long COVID. I think as is a theme here, this is also an active area of research. There was a promising study in Great Britain and the UK using a cell phone app where people report their symptoms and can also report a new diagnosis of COVID-19. It has included well over 1 million people over the course of the pandemic, and it published a study looking at symptoms that are both acute, so shorter-term symptoms, and longer-term symptoms among people that had been vaccinated. And because this was last year, before that we were talking about boosters even, or last year, earlier in the year, before we were talking about boosters, it was looking at then effects of 1 dose of a vaccine and 2 doses of a vaccine as well. And I included one of the figures from that study here on the right, and you can see there that in blue are the odds of developing some of these symptoms lasting greater than 28 days amongst people who received 2 doses of a vaccine. And so when they compared people that were unvaccinated to those who had received 2 doses, the symptoms lasting 28 days, the odds of those were lower, both in younger adults and older adults. And so promising that being vaccinated would limit the risk of developing long COVID after a breakthrough infection. But that's just one study, and we certainly need more. There have also been some other studies suggesting that if you're already experiencing long COVID and then you receive a vaccine, that the vaccine itself can help to alleviate the severity of some of those symptoms. But that's also needing to be studied further as well. But some promising signs. Okay, and then as we transition into our second topic of pediatric COVID vaccines, are children at risk for long COVID? And if you thought that long COVID was understudied overall, then looking at children specifically, it's really been understudied. There are even fewer publications, fewer investigations looking at the risk in children, but it does appear, at least in what we know so far, to be slightly less common. Even if we don't know the exact risk, the risk does appear to range. You can see there between 0 and about 15% or so, which is lower than what we're seeing in adults. Though one of the key studies looking at chronic inflammation as a cause of COVID, a cause of long COVID, did come from a research study of children, where they did look at the blood samples of children who were experiencing some of these long-term symptoms and continued to see very high markers of inflammation that persisted among those with long symptoms. I included there something that we would call a heat map on the right that was taken from a publication in the Journal of the American Medical Association. And this is how common different symptoms were in children days and weeks after their initial acute COVID infection. And you can see there that as as the boxes become darker, the proportion or the percentage of children reporting those symptoms is higher. So fatigue is really what stands out and persists long into the post-acute COVID phase, as well as something called anosmia, and that's the lack of smell. So it does seem like some of these symptoms, especially fatigue, can persist longer in children. Difficulty concentrating and difficulty in participating in activities at school has also been well described. It may resolve faster than in adults, going back to what we said in adults, that higher levels of health going into the COVID infection and development of long COVID may help with recovery, and that could be why we're observing that in children, but certainly more study needed. So another Ask Me 3 situation that we'll walk through together. I have 3 children at home. 2 of them are too young to be vaccinated, and they both go to daycare. My oldest child is in middle school and has a learning disability. I worry about their risk of getting COVID, especially because there's so much we don't know about the long-term symptoms. So what is the problem? COVID-19 can infect children and certainly can lead to long-term symptoms, just like in adults, although maybe less common. What do I need to do? If your child is eligible, getting them vaccinated reduces their risk of infection. And if you have questions about the vaccine, talk to your child's pediatrician. I have young children at home. Neither of them are eligible by the CDC's criteria for vaccination. So what we have done is try to surround them with as many vaccinated people as possible. So getting more people in the family vaccinated and now boosted makes the entire family safer, especially when we have members of the family that are vulnerable or very young. And why is it important for me to do this? Vaccination is the best tool that we have currently to prevent the spread, infection, and complications of COVID-19, including long COVID. Okay, so with that, since we started talking about children, we'll spend the last few minutes of our chat today focusing on COVID-19 vaccinations in children. I think what I would take away from this initial slide, which is a little bit different from the very first figure I showed, is here on the right, these different figures represent the proportion or the percentage of new cases of COVID-19 amongst our youngest members of our community. So kids between the ages of 0 and 17. And you can see that over the course of the pandemic, those numbers have increased to the point where now in the beginning of December, about 17% of all new cases of COVID-19 are amongst children. Thankfully, hospitalizations have remained low, though the kids are definitely hospitalized from COVID, and anywhere at any given point in time, about 2 to 4% of hospitalizations across the country are in children under the age of 18. What we did observe, and that may partially explain the phenomenon of rising hospitalization rates amongst kids, is the onset of the Delta variant, where we did see a tenfold higher risk of hospitalizations amongst young children and unvaccinated teenagers. So despite that higher risk, the risk is substantially lower than in adults, thankfully. The figure here shows the rates of hospitalization during the course of the pandemic for different decades of life. It's even difficult to see at all the yellow lines that represent hospitalization rates amongst children. This continues to be a disease affecting adults, especially older adults, most severely. However, when we're talking about young children, really any severe outcome or any death due to COVID-19 is really a tragedy and in many ways should not happen. And so even small numbers can still be very impactful on our youngest members of our community. And so this figure here is from the Kaiser Family Foundation. It looks at COVID-19 as where it ranks in the top 10 causes of death in different age groups. And you can see there that in the month of October, which was the most recent month we had data for, that amongst teenagers, it was the 4th leading cause of death during the month of October, and for 5 to 14-year-olds, the 6th leading cause of death. So even though the numbers in total are low, these are for young children that are otherwise healthy, COVID-19 can still be quite devastating. And I think that these numbers speak for themselves and how important the issue of childhood vaccinations are. Another severe outcome that we can see that I'll just touch on briefly, that even though it doesn't contribute to death, can lead to hospitalization, is something known as multisystem inflammatory syndrome, which you can read about more on the CDC or the American Academy of Pediatrics, both of which have great online resources to discuss this further. It is a syndrome that appears to be related to the inflammation in the body that the SARS-CoV-2 or COVID-19 virus triggers when children become infected, and is really seen in younger kids between ages of 5 and 11, and often leads to hospitalization. There have been over 100 cases reported in Maryland during the pandemic so far. I think even probably the most impactful of everything that we've spoken about so far on with regards to children is the pandemic's impact on school and the missed learning opportunities and learning loss as a result of the pandemic, whether it be because of hybrid or virtual classrooms and how challenging that can be for some students, the isolation that is needed after COVID-19 infection, or quarantine that can happen sometimes to entire classrooms after exposures, and not just the learning deficits, the learning loss that occurs, but the social and emotional impact that has on children and on their families as a result of remote learning. The economic impact that has on families that are helping to care for children at home as well. And so because vaccination can lower the risk of infection and also reduces transmission to others, even when a breakthrough infection occurs, vaccination, in addition to masking, is one of the most important tools that we have to keep kids in school and keep them on track so that they learn and progress through their schooling. So finally, and I think this is one of our, we do have couple more slides after this, I apologize, but we'll talk about childhood vaccinations using Ask Me 3 one more time. I have a 6-year-old daughter at home with asthma. She uses an inhaler every day and has even been hospitalized in the past with an asthma exacerbation. I wonder about what would happen if she got infected with COVID-19, but I'm also unsure about the possible side effects of the vaccine. So what's the problem here? COVID-19 is less severe in children, but can still rarely cause serious illness and even can lead to hospitalization. And this is especially true for kids with underlying health conditions, and I would definitely include asthma amongst those that would put a child at higher risk. And so what do I need to do? If you're concerned about the safety of the vaccines, if you'd like to learn more about the vaccines, that's a great topic to discuss with your child's pediatrician. Speak to them about your concerns. Speak with any trusted friends or family who have taken their children to get vaccinated. And you can also look at trusted online resources, such as the CDC, that has plenty of information about how the vaccines were developed and how they work, so that you can better understand and make a decision for your family. Why is it important for me to do this? Because even if they are rare, even one serious complication from COVID, as I mentioned, in a child is one too many. And so vaccines are a safe and effective way of preventing those severe complications and making sure your child stays healthy during the pandemic. So in the last few minutes, I'll talk about the clinical trial itself that led to the approval of the Pfizer COVID-19 vaccine for children aged 5 to 11, the most recent approval that passed through the FDA and the CDC. And then we'll open up our conversation for questions. So the Pfizer vaccine is currently the only vaccine authorized for children in that youngest age group, 5 to 11. It was authorized in early November. In the clinical trial, the study investigators did what's called randomization, where using a computer rather than taking first come first serve or selecting people based on conversation, it's just a random, almost like a random number that's generated that assigns a child yes or no to receiving either the vaccine or what's called a placebo. And it was done in 2-to-1, so that every 2 children that received the vaccine, 1 received the placebo. And this is really so that we can compare both and understand fully the side effects and safety profile of the vaccine, but also how well it works in preventing COVID-19 infection. And really the gold standard for scientific investigation. So this is a lower dose of the vaccine that was used for older children and adults, and the dose was selected in even clinical trials prior to this one, and looking at, again, safety profile and how well it generates antibody levels and immune response from our body. It enrolled over 2,000 kids in 90 sites in 4 different countries. I think it's very notable that in the past, especially amongst adults, the clinical trials for the COVID-19 vaccines have been very, very diverse in making sure that both geographically and from a racial and ethnic standpoint, the studies have been quite diverse. Maybe a little bit less so. I think in this pediatric study, 79% participants were white, but you can see there that 21% identified as Hispanic or Latino, and 7% identified as multiracial. The figure on the right shows the risk, or I should say the incidence, meaning new cases of COVID-19 that occurred during the clinical trial. The blue line represents those that received salt water into their arm, placebo. The red line indicates the COVID-19 cases that occurred in those that received the vaccine. And every time a case occurred during the study period through 3 months, the line goes up a notch or 2. And you can see there the dramatic difference between the 2 groups, that those that received the COVID-19 vaccine were protected from developing symptomatic COVID-19 infection as compared to those that received the placebo, with a 90% vaccine effectiveness. The side effect profile looks very, very similar to that seen in adults. though actually might be overall a little bit less common, and in part that's because of probably the lower dose that was used and was well studied before this final phase of the clinical trials. That lower dose helped to reduce the side effects while still leading to a very good immune response and level of protection. They're generally mild, last 1 to 2 days. There have been 5 million doses given to children under the age of 12 across the U.S. thus far, and there have been no serious safety signals identified since the vaccine was authorized. And I know that this is certainly a concern for parents. No cases of myocarditis identified. Studies in younger children are ongoing, both in with other vaccine manufacturers like Moderna and Johnson & Johnson, as well as studies in younger age groups as well, down to 6 months of age. And I mentioned earlier that I myself have younger children, and just to share with you my strong support and belief in the scientific process that in these vaccines, my wife and I had the opportunity to enroll our 1-year-old in one of the clinical trials, and so she's currently receiving, we're not sure, either the vaccine or a placebo, but is part of the process in making sure that the vaccines are safe and effective for really our really youngest kids, and hopefully we'll see the results of that study in the next couple of months. So with that concludes my part of the conversation today, and now we'll move on to questions, and hopefully we can generate some more good discussion.
Dr. Schrank, thank you for that. You have a really unique way of taking a load of information, some of which can be very complicated or frightening, and making it very clear and plain. So appreciate that and say thank you on behalf of our audience. We do have a number of questions, and I'm going to maybe apologize up front because there are some that are coming in asking about post-viral circumstances and infections generally. So I'm going to take those related specifically to long COVID first, and if we have time, deal with those others. There's a clarifying question here. One person asked, what is myocarditis? I want to start with that since it's definitional.
Great, thank you. And sometimes I slip into medical jargon. So thanks for asking. Myocarditis is an inflammation of the heart. This is something that was found to occur very rarely in young adults, specifically in male young adults in their 20s and into early 30s. In people that had received the 2 mRNA vaccines, Pfizer and Moderna. It appears as though there is a very low risk of a mild inflammation of the heart that can occur after the first or second dose of the vaccine, and is linked to the incredible amount of immune response that our body has to the vaccine. It, in almost all cases, is mild and has been what's called self-limited, meaning it resolves on its own without permanent damage to the heart. I think it's important to note as we think about the potential side effects of the vaccine is the alternative. And so there's actually just this week a very, very well done study looking at the risk of heart inflammation amongst people who received one of the vaccines and who were infected with COVID-19 that were unvaccinated, and the risk of heart complications, including inflammation of the heart, heart attacks, and arrhythmias or abnormal heart rhythms, is substantially higher if you experience a COVID-19 infection. Very, very high in comparison to any side effect from the vaccine itself.
Great, thank you. I'm going to try to combine questions where they're related because there are several. So there's a general question that says, what kind of treatment plans exist for long COVID? But then there's a very specific question, which I think will get to the same place, which is, I had a mild case of COVID-19 in March and was never hospitalized. After 9 months, I'm still suffering from brain fog, fatigue, and body pain, and had to reduce my work hours. All tests so far come back negative, and my doctor doesn't know what to do with me. It's frustrating and discouraging. I used to be healthy, very active, and had no previous health conditions. What should I discuss with my doctor, and how can I help her help me?
That's a great question, and I thank you for sharing your experience, and I'm sorry that about everything that you've gone through since your COVID-19 infection. And I think we discussed today that there are many people in your exact situation that seemingly had mild COVID and then have gone on to develop long-term symptoms that in many ways are worse than the original infection. So going through, it sounds like you and your doctor have gone through some of the initial important steps, and that's trying to figure out if there is another cause of these symptoms to make sure that we're not missing something else that may have just coincidentally also occurred after your infection with COVID-19. If that has, if your doctor is sort of exhausted and gone through all of the other considerations, then I think at this point in time, it's quite possible that you're experiencing long COVID or post-acute COVID-19 symptoms, in which case, treatment is very, very much tailored to the individual. And I think that goes to the other question that Donna combined with this, is that it's very much dependent on the symptoms that you're experiencing. So if they are primarily related to trouble breathing, chest discomfort, sometimes that can be physical therapy that's primarily aimed at improving a person's exercise tolerance, slowly increasing the amount of exercise that they're doing, the types of tasks that they're doing, and the amount of exercise that's required to do those. For an individual that's experiencing difficulty with concentration, that may be more based in some what we would call neurocognitive therapy, therapy designed almost in the way that somebody that has another type of brain problem, whether it be that they're recovering from a stroke or having signs of some form of early dementia symptoms. There are specialty centers that have experience in helping people work through challenges with thinking and with concentration, with anxiety, with sleep that can all occur after critical illness. And so specifically going back to the person that asked the question about their own health, I would talk to your doctor and see if it's possible to be referred to one of the post-COVID care clinics that exist across the state. As you can imagine, this is an area of emerging study, and it's not quite everywhere yet that they have these clinics. But within the University of Maryland Medical System, we certainly do have them, and I think that would be good for discussion with your provider to see if a referral to one of those clinics would be in your best interest, and then you can begin further evaluation there with one of our specialists.
Thank you for mentioning that. There are a few questions that are very specific to an individual's circumstances, and I usually say up front that we're not going to be able to answer those kinds of questions, but if people can be directed to a clinic where they can get that individualized response, that would really be helpful. Okay, let me try to combine a couple of others. One is, what's on the horizon? We're reading about potentially from Pfizer a pill that may treat COVID, and then someone specifically says, is there any sense of when other vaccination options will be available for younger children from Moderna, from J&J, et cetera?
Right. So the first question about other treatment options. So right now, in terms of therapies, there's the vaccine, of course, that is designed to prevent infection or reduce the severity of infection should it occur, also reduce transmission risk. There have been multiple what's called monoclonal antibody therapies developed. So this actually works in a similar way to vaccination in that there are antibodies that grab onto the virus and help to eliminate it from the body. They've been created in a laboratory to sort of look exactly like things that antibodies that our own bodies would make. And they can be given either through an IV or even injected under the skin. We have numerous different sites across the state of Maryland that are set up to establish these treatments and provide these treatments to people. And they can be given either to prevent infection after an exposure, or for people that are really high risk, whether because of their vaccination status or because of their medical conditions or age, they can be given as part of a treatment program to, in essence, immediately boost the amount of antibodies that we have quickly after you develop an infection. And they are really good at preventing hospitalization, though we have seen as variants have developed over the course of the pandemic, some of them are becoming even better at evading or escaping the antibodies that we've created. And so further tweaking to some of those treatments are certainly needed, especially with the Omicron variant that we're seeing now on the rise. And then lastly, the antiviral medications, the pills. There was just a press release from Pfizer this week looking at an oral medication. And I would think of these in a way to what Tamiflu is like for influenza, that they're medications that would be given after the onset of illness and best when taken very early on when the most amount of virus is circulating in our body, and can not only help hopefully with preventing severe illness like we saw with some of the data from the Pfizer press release, but also really ideally also reduce the amount of virus that we're shedding and hopefully prevent transmission as well. That would be another great benefit of these medications. And I actually think that it's particularly exciting to see these oral antiviral medications start to hit the market, because they work in such a different way that even when we start to see more and more variants emerge and with concern about how our antibodies will work against them, we don't really have to worry about that as much with these oral antiviral medications. And so it's expected that this latest drug, especially from Pfizer, will work very well against the Omicron variant as with Delta.
All right, I'm going to take a couple of specific questions and then a combined, and then we're going to be out of time. Dr. Schrenk, however, has said he would be happy to take a look at the questions we didn't get to and see if he can provide answers, as I mentioned, in a couple of days. So I think there are a couple of that are important. You mentioned a moment ago, and I think we should emphasize this, that the vaccines are intended to reduce the severity of COVID-19 should it be contracted and potentially avoid hospitalization. I do think that for much of the public there's been confusion and maybe some angst or concern that people are still contracting COVID-19. Can you comment on that so we can get some clarity?
Absolutely. So there's a couple of things here, and this is there's not one answer to this question of why people contract COVID after being vaccinated, but I think that I can kind of break it down into at least three different reasons why that might be occurring. So one is that when we're vaccinated, our body immediately develops a really high and strong immune response. The vaccines, as part of the studies done during Operation Warp Speed last year during 2020, the clinical trials were designed to try to get to the end of them and get the vaccines available to people as quickly as possible, still while being as safe as possible, but done as quickly as possible. And so the vaccines were spaced out just a few weeks apart. If you think back to childhood, and even to some of the vaccines that you still receive as an adult, we don't space vaccines out 3 or 4 weeks. We generally space them out months, maybe even years. The polio vaccine is given months apart and over a few years. And with each dose of the vaccine, it generates a stronger immune response, helps our body to remember, and also it leads to the immune system kind of evolving and maturing a little bit, better understanding the virus. So that way it's even more effective at preventing complications and severe illness, or even illness altogether, as it learns and as it grows. So I think one thing that we've seen with the vaccines is a decline in our antibody levels over time that is very much expected, and in part relates to how this was given as 2 doses very, very close together. I think if we had all the time in the world to develop this vaccine regimen, it probably would look more like 2 or 3 doses, but spaced much further apart. The other thing is variants. So we've seen these variants that have these changes in their shape that don't allow our antibodies to bind as well to them. That's probably why we started to see, especially in July, August, September, more and more cases amongst those who were vaccinated as Delta, which has many of those changes on its spike protein where our antibodies are targeting. As those changes occurred and the Delta variant became much more common, we saw people developing more breakthrough infections. But because our immune system is more complicated and much more intelligent and sophisticated than just antibodies, we have a whole bunch of other cells that help our immune system when there's something new that maybe our antibodies aren't quite as good at recognizing. They quickly say, hey, this is something that I kind of know, I recognize it, but we need something new and different to help take care of it. And so we have B cells, we have T cells that recognize it, attack it, and then actually generate new antibodies that are specific for either Delta or now Omicron. And so our bodies we need to give them lots of credit, and we can help turn on the factory for those new antibodies, so to speak, in just a few days after getting infected. So it may not mean that protection against symptomatic infection is quite as high as it was at the start, within a couple of weeks of getting vaccinated, but our bodies are able to generate a good immune response and have some memory to protect against severe infection by starting to make new antibodies against that variant as it comes across. And then finally, is people that remain vulnerable. And so those are people that are in the advanced stages of life, in their 70th, 80th, 90th year, and just don't have the same immune system that they did when they were younger. And this is a phenomenon that goes well beyond COVID, that antibody response isn't quite as high after vaccination. The other parts of our immune system are kind of a bit quieter and aren't as robust. And so those individuals, we saw that even as when there was a bit of an erosion or a decrease in effectiveness of the vaccines at preventing infection towards the end of the summer with the Delta variant, we actually saw a little bit of an uptick in hospitalizations amongst the vaccinated, especially in older populations, or those with chronic medical conditions like cancer that may prevent an immune response from being generated at all. And that's where boosters really have come in and are the biggest benefit in those most vulnerable. There was a fantastic study done and published a couple weeks ago, a randomized controlled trial. So just like what I described in kids, where some people are selected to get a booster, some people are not, and showed a very dramatic benefit in preventing death amongst especially the older and more vulnerable members of the community that were included in the study amongst those that had received the booster. So booster not only better in the face of variants now at overcoming some of those mutations, but also really, really important for people that may not have generated as high of an immune response to begin with.
Okay, we're pushing up on the 1 o'clock hour, so I've got 3, let's call them lightning round questions.
Okay, yeah, we'll do it.
Fine. Okay. So what's fully vaccinated now? Is it 2 doses of a 2-dose, 1 dose, or is it that plus a booster?
Yeah, that's a great question. I think that, for the purposes of what we call, the public health definition, so that's having your vaccine card, and if you should need it for travel or going into a restaurant or going into a concert, something like that, 2 doses of Pfizer or Moderna, 1 dose of J&J is considering somebody fully vaccinated. As we know, the CDC has recommended boosters for anybody that received Pfizer or Moderna and is 6 months out from their second dose or 2 months out from a J&J. And they recommend it for anybody over the age of 18 for the 3 vaccines and over the age of 16 for Pfizer. And I think that's really how we should think about these vaccines now. I mentioned earlier that probably in an ideal world, it wouldn't have been 2 doses 3 or 4 weeks apart. That's why boosters are so critical now, especially in the face of the variants. And I really strongly encourage anybody, especially going into the holiday season, to get boosted. The immune response comes quickly within just a matter of days, and it can really bring up our level of protection back to close to where it was after our second dose.
And how long can you delay a second dose of a 2-dose regimen? And is it the same for children?
So there's really no endpoint at which you couldn't receive a second dose anymore, or we would consider you to be restarting. The doses, the regimens and the protocols are designed to be 3 and 4 weeks apart. pushing it out a little bit more, it delays you having that boost in immune response again. But in some ways, the vaccines were actually more designed. Our body was more designed to respond to vaccines further apart. In the midst of the surge that we're experiencing right now, though, I would encourage people, if they're not vaccinated, to go ahead and get the doses as close together as possible, and then worry about boosting down the road when you're eligible. Get that full vaccination series done as quickly as you can.
All right, that's great. And this question is really important for us circulating in the population, I would say. So once my child is 2 weeks post-vaccine, are they okay to be unmasked in a group setting with unvaccinated children?
That's a great question. So I think we have to take it in the context right now of what we know is going on, and that's a surge in Delta and a surge in the Omicron variant. And even though Omicron is still just only about 3% of the variants across the country right now, what we've seen elsewhere is that can quickly become 15, 20, 30%, 50% in just a matter of a couple weeks. And it is better at escaping our immune system than previous variants. And so I would say that in a child who's able to mask, if they're around others that especially are unvaccinated, masking is safest. Especially because if God forbid, your child were to become infected with COVID-19, even despite being vaccinated, them wearing a mask helps to protect all those other children that are not yet vaccinated, whether they're because they're not eligible or just because they haven't had an opportunity yet. And so I think that masking is not only, it's important for ourselves, but in many ways it's just as important, if not more important, at protecting those around us. And so I would say if your child's able to mask, and I know it's sometimes hard, but I can get my 3-year-old to wear a mask most of the time when we're indoors. I would go ahead and keep the mask when they're around others.
All right, so the last question for today, how fearful should we be about Omicron?
Great question. There's a lot that we still don't know, and I know that that's not the answer you probably were looking for, but it's the honest answer, in that there is a lot of early data that suggests that people that have been boosted are still well protected against severe disease. But people that have not been boosted, or certainly are unvaccinated, are very susceptible to this infection, or to this virus and this variant that appears to be really, really transmittable and moving through communities very quickly. And so even if it turns out that it causes more mild disease, which I know we're seeing in the headlines, and personally I still think it's a bit too early to call that one, if it causes many, 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 many infections, it's just a simple equation that even if it is less likely to cause severe disease, if there are millions more infections, it can cause a lot of cases that require hospitalization. And so I think we need to go into the next few weeks with our eyes wide open, make sure that if we're experiencing symptoms, get tested, keep on your mask, especially one that's well fitted, multi-layered, like a KN95, or at a minimum, a medical grade mask if you're going indoors. And around others that aren't a part of your immediate family, and then getting boosted if you're eligible.
Dr. Schrenk, let me say again, thank you very much for this very informative talk. If we can have the next slide, I want to just mention a couple of things for our viewers and listeners. So as I mentioned at the beginning, you will be able to see this video presentation again, should you choose, at ums.org/let's talk, and we'll try to look at any questions that were not addressed here and upload them, although we did get through most of them. The other thing I want to mention for the group is you can also see all of the prior sessions. They're there as well. You can pull up any of those. Resources. Dr. Schrenk mentioned the CDC. You can always go to CDC and search coronavirus. There's up-to-the-minute information. He mentioned the American Academy of Pediatrics, which has a wealth of information related to COVID and children and vaccines. And also for UMS, we have ums.org/coronavirus. And there you can get basic information about the virus itself, or you can also search and get more information about vaccines. There's a question here, Dr. Schrenk, you mentioned long COVID clinics, and someone asked, could we put up a list of those, and maybe we can just put that up online, and certainly give the reference for the UMS location. But once again, Very detailed, great information, important in the midst of this pandemic. So I'm very grateful to you for this. And then one last slide before we conclude, which is our next session. We do the third Wednesday in every month, again at noon. We're going to be talking about pharmacy and medication management. So once again, thank you, and thank you all for joining us and for the magnificent questions that you've shared today. And everyone stay safe. Have a healthy holiday.
Thank you, everyone.